grateful for. So this webinar is because of the inauguration of the Lipid Clinic at the Shab Teaching Hospital, which is the first lipid clinic to be opened in Sudan. We are grateful for Dr. Mutaz Al-khnifsawi for his efforts in helping support us through the process and encouragement to start service in this field. It was his idea, and we have spoken a number of times, and we're proud to be a part of this network. But without further delay, the webinar for tonight will be we'll have a number of speakers. We'll have Dr. Mutaz giving us a talk on what is a lipid clinic, followed by Dr. Mujahed Mohamed, will be giving us a brief talk on the latest guidelines on lipid management for the primary and secondary prevention of ischemic heart disease. And then we will have Professor Abdulmunim Assid, the Sudan Heart Society president, delivering a talk on unmet needs in lipid management in Sudan. I will introduce now Dr. Mutaz Al-khnifsawi. He is a preventive cardiologist and a lead investigator at the Imperial College EAS-FHSC Familial Hypercholesterolemia Society. He is the president of the Iraqi Lipid Clinics Network, and he is a member of a number of prestigious societies, including the European Atherosclerosis Society and the International Atherosclerosis Society. He is a member of the executive committee of the International Atherosclerosis Board or Committee, and he's representative of MENA and Africa, and hence his role in initiating this service in Sudan. Dr. Mutaz, we are proud to have you as a friend of Sudan, a friend of the Lipid Clinic at Shab Teaching Hospital, and I would be grateful if you can deliver your talk and enlighten us about the lipid clinics and what it means and what kind of services we can provide to our patients. The floor is all yours now.
Thank you very much, Dr. Ahmed, for the very kind invitation to attend this historic event. Actually, despite the very exceptional circumstances your country is passing in, but because of your enthusiasm, your courage, now Sudan is the first Arabic country in Africa to establish a lipid clinic. I am carrying the greetings of Professor Raul Santos, the president of the International Atherosclerosis Society, and Professor Kausik Rai, the president of the European Atherosclerosis Society and the head of the Familial Hypercholesterolemia Study Collaboration Team at the Imperial College, to our colleagues in Sudan for this historic achievement. Familial lipid disorders are common disorders with devastating consequences. Both familial hypercholesterolemia and familial hypertriglyceridemia shortens the life expectancy for people. They have devastating cardiovascular mortality and morbidity. The prevalence of familial hypercholesterolemia worldwide is one patient in every 250 healthy subjects for the heterozygous form of familial hypercholesterolemia. That is the less severe form of the disease. And one in every 300,000 individual for the more severe form called homozygous familial hypercholesterolemia. It is estimated to have 35 million people worldwide affected with this disease. The problem here is that only 10% of patients are diagnosed with this disease. The remaining 90% is still escaping the diagnosis. This happens because of lack of awareness among both public and even healthcare professionals. It is estimated from the FX Foundation that 85% of cardiologists worldwide are unaware of the magnitude of the problem. So if a patient with lipid disorder want to seek for medical advice, there is no special clinic to which this patient can seek consultation. He will consult internists or cardiologists who are many in each country. So a lipid disorder can be treated better by a well-trained physician. A lipid clinic is that clinic which deals with patients with familiar lipid disorders, familiar hypercholesterolemia and familiar hypertriglyceridemia, particularly familiar hypercholesterolemia. This disease is a genetic disorder in which excess cholesterol will lead to a premature cardiovascular mortality and morbidity. This disorder is undetected, as I told you, because of lack of awareness. We noticed in 2015 that developed countries have a specialized lipid clinic dealing with these disorders. So we transferred this experience first the Middle East, first to Iraq. In Iraq, in 2017, we established 12 lipid clinics from covering all over Iraq, from the north to the south. Then we transferred this experience to Syria. We established the first lipid clinic in Damascus, in the heart of the capital, Damascus, last March this year. And now we transfer this experience to your country, Sudan, to establish the first lipid clinic, Khartoum Lipid Clinic. The success of lipid clinic depends on the level of activity of the physician who is in charge of this clinic. We are in need to arrange a symposium, talk with public, with nursing staff, with young physicians to tell them more about lipid disorders. And even dermatologists, because the skin manifestations of familial hypercholesterolemia push the patient toward a dermatologist. They think that it is a pure skin condition. The dermatologist will remove this skin lesion, and he is not aware that this is a lipid disorder, familiar lipid disorder, not a pure skin lesion. And the lesion will return back, and the patient will be in a closed circle. So we are in need to recruit the social media to talk to the people of Sudan about the prevalence of lipid disorders, how we diagnose them, and most importantly, the skin manifestation of these disorders. In Iraq, we arranged many symposiums with different community layers. Even the teachers in the primary school, because they are examining children frequently during the day. So a physician who is responsible about this lipid clinic should be a qualified cardiologist or internist who must have high level of activity in talking to people. We can use the TV or radio station to talk about these disorders to aware people and the healthcare professionals. it is not easy, but it needs a long time of work. How we shall support your project in Sudan? We are, as international FH community, will provide training courses for physicians who are responsible about running this lipid clinic. And this is not for one time. Every year we have a course held in Muscat, and I have some colleagues from Sudan already attended this course. We shall train them in fully sponsored grants about lipidology and atherosclerosis by the hand of many experts in the International Atherosclerosis Society and Middle East. This course is arranged every year. So every year we can send one at least or two maximum physicians from Shab Hospital to train them to be qualified enough to deal with these patients. In addition, we have in the severe hypercholesterolemia study collaboration team in the Imperial College. We have a national lead investigator for every country. Sudan currently has no representative. You will nominate one of the colleagues in a Shab hospital to represent Sudan in this prestigious international team. This will enhance collaboration among other national lead investigators from around 66 countries. You will publish
Hello, I seem the sound is cut off.
Hello, can you hear
yes,
me?
Yes, now you're back. Yes, please continue.
Okay. You will collaborate with other national lead investigators in this prestigious team to publish your data in most prestigious journal, and this is a very good opportunity to show the position your country deserves in this international team. In Iraq, we launched some strategies to control this disease. As you know, in addition to losing lives because of untreated familial hypercholesterolemia, there is a heavy economic burden for treatment of these disorders, because familial hypercholesterolemia usually needs more than 2 drugs to be treated. For the heterozygous form, you may have monotherapy is enough. For the homozygous form, maybe not enough. The younger, the newer generation of lipid-lowering agents are very expensive, and this adds an economic burden on the budget of
It seems the sound is breaking up from Dr. Mutaz's side. We will wait to see if he's able to join us again. Is everybody able to hear me? Can we get confirmation that you're able to hear me?
Yes.
Then it must be from Dr. Mutaz's side that we are not able to hear him. I think till he's able to come back, I will continue. I will come in with a few comments. The chat area is very busy, and I think part of the Lipid Clinic service is not just the clinical part, which is important, but it also involves research work, registry data, and people are asking about the how do we refer patients. I think very soon we'll have an announcement about how to refer patients. You know, this is a public hospital, so we're working with the director of the clinic service, مدير العيادات المستشفى. So we can start the clinic officially, have a referral, and also the statistics department at IHSA, so that we can have records of the patients. So we're expecting during this week, we will have a portal for referral of patients at the Shab Hospital, inshallah. And again, we're also interested in young researchers who will be able to help us with data, registry data, and hopefully research projects part of this clinic. I think Dr. Mutaz is still not there. The other important issue, I think Dr. Mutaz has said that this lipid clinic is part of a lipid network. We have support of the European as well as the International Atherosclerosis Society and the familiar hypercholesterolemia group from the Imperial College. And we'll have a seat. So now we'll have a seat at that the Imperial College familiar hypercholesterolemia group. He was also talking about training, that we'll have young cardiologists who will get training in Muscat. We have this annual meeting whereby young cardiologists will get fully sponsored trips and course to Muscat. Hopefully it will be done physical. You know, the COVID-19, it hasn't been done the last. Yes, Doctor. Yeah, now you're back. So
okay, I'm sorry. I have just 1 minute to finish my talk. Something wrong with the internet connection. Can you hear me?
Yes, we do hear you. Please continue.
So the last minute of my talk is that the objectives of the Lipid Clinic is to increase awareness among public and healthcare professionals about this disease. I shall cooperate personally with the physician who will run the clinic to tell him or to guide him how to initiate this awareness machine using the social media. And the second objective is to early detect and properly treat patients with familial lipid disorders, particularly familial hypercholesterolemia. So I'm very pleased to assist, and I wish you all success in your project. Thank you very much.
Dr. Mutaz, before you go, because we have a number of late comers and the sound broke off, give us 1 minute again. Give us one minute summary. If you can give us a summary of your message, so that those who have joined us late can benefit from what you have said. Some have come in late, and the sound broke off. Just give a minute or two of a summary of the major points that you want the audience to get, if you don't mind.
Yeah, familial lipid disorders are very common disorders affecting almost 35 million people worldwide, and especially in our countries where consanguinity is very common. This disease is a serious problem in our region. The problem with these disorders are underdiagnosis. Only 10% of these disorders are diagnosed. The remaining 90% are still undiagnosed. The risk of these disorders are premature cardiovascular mortality and morbidity. If these disorders are untreated, we shall lose many lives, as well as the the heavy economic burden on the budget of the Ministry of Health in your country. So the objectives of establishment of a lipid clinic is to increase awareness among both public and healthcare professionals about the magnitude of the problem, the definition of the disease, how to diagnose the disease, and the devastating consequences, right? So these are the objectives of establishment of a lipid clinic, and we shall assist all of you by guiding you how to recruit the social media machine to talk to people of Sudan about these disorders and how much it is important to early diagnose these disorders. We have two strategies we launched in Iraq. This may help to control the disease in your country. The National Pediatric FHSC Screening Program to diagnose the child early and to give a treatment so avoid the complication. And we have our unique strategy launched last year, that the premarital FHSC screening program. We screen the premarital couples to see whether they are heterozygous familial hypercholesterolemia cases and whether this disease will be transmitted to their children. So I wish you all success, and I am with you in both guiding the treatment and providing training opportunities for young physicians who run the clinic. I wish you all the best in this excellent project, and thank you very much.
Thank you very much. Thank you very much, Dr. Mutaz. Thank you for being patient with us and giving this great summary. Mujahed, are you ready for your presentation? Mujahed, are you ready for your presentation?
Yes.
Thank you. So, excellent. So let me introduce you. I'm happy, I'm very honored to introduce Dr. Mujahed Mohamed, also known as Mujahed albasha. Is one of the young cardiologists who has been working in my unit at Shab Teaching Hospital. Is one of the promising young doctors and young cardiologists. He has shown interest in leading this project, and he will be leading the project at Shab Teaching Hospital. He shares the common vision that we have, despite that we are a very busy clinical unit and very busy intervention cardiology clinic. I think we have a common vision that we need to work on prevention and improve preventive efforts, especially when it comes to lipid management. Without undue delay, Dr. Mujahed albasha will present to us review of the latest guidelines of the lipid management for the primary and secondary prevention of atherosclerotic cardiovascular disease. Mujahed, the floor is all yours.
Assalamu alaikum. Thank you for everyone. I want to give you short notes about review of latest guideline on lipid management for primary and secondary prevention of atherosclerosis. Prevention of cardiovascular disease, prevention call for all patients, apparently healthy people, should be calculated 10 years cardiovascular risk. As you know, to calculate the 10 years cardiovascular risk depends on the age, systolic blood pressure, and total cholesterol, and gender, if male, differ from the female, and smoking. And also patients with established atherosclerosis cardiovascular disease and a specific condition like diabetic, CKD, familial hypercholesterolemia. And also should be know the cardiovascular risk estimation. And then classified the people to two groups, individual level intervention and population level intervention. In individual level intervention, lifestyle modification, physical activity, body weight reduction, and nutritional health, and treat the psychological factors and should be treated the risk factor. And the major risk factors, smoking and lipid, treated the dyslipidemia by lipid lowering drug, should be treated the blood pressure, and should be controlled the diabetic, and antithrombotic therapy if needed, and disease-specific intervention. The population level intervention, public health policy and advocacy, specific risk factor intervention at population level, physical activity, diet, and reduction alcohol, and cessation of smoking, and also environmental control, air population, and climate change. In atherosclerosis cardiovascular disease, should be know the cardiovascular risk category, classified to 4 groups: very high risk factor, high risk factor, and moderate, and low risk factor. Here we discuss the very high risk factor and high risk factors. The very high risk factor groups, if patient documented atherosclerosis cardiovascular disease, either clinical or by image. Documented by clinical, like previous SAS, MI, unstable angina, stable angina, coronary revascularization by PCI or CABG, and other arterial revascularization procedure. Also stroke and TIA, peripheral arterial disease, and also documented atherosclerosis cardiovascular disease by image, like coronary angiography, CT coronary angiography, or invasive coronary angiography. Also, if patient diabetic and with target organ damage or more than 3 major risk factors, or early onset of diabetic type 1, long duration more than 20 years. Also severe CKD FGFR less than 30. Also if calculated score more than 10 for 10 years risk factor fatal cardiovascular disease. The last one, familial cholesterolemia with a atherosclerosis cardiovascular disease or with another major risk factors. The major risk factors, hypertension, diabetic, dyslipidemia, smoking, and family history of atherosclerosis cardiovascular disease. Next one, patient high risk. If markedly elevated single risk factor, particular total cholesterol more than 8 millimole per liter, or LDL cholesterol more than 4.9 millimole per liter, or blood pressure more or equal 180 over 110. Or the patient with familial hypercholesterolemia without other risk factor. Or patient diabetic without target organ damage. As you know, the target organ damage means patient with microalbuminuria or retinopathy or neuropathy. Or patient diabetic duration more than 10 years, or another additional risk factor. Also moderate CKD GFR 30 to 59, or calculated score 5 to 10%. The score, calculated score for atherosclerosis, estimated by score is standard for systematic coronary risk estimation. The new recommendation about atherosclerosis cardiovascular disease and lipid management in apparently healthy people less than 70 years age without established atherosclerosis cardiovascular disease, diabetic, CKD, genetic carrier lipid or blood pressure disorder, estimation 10 years fatal and non-fatal cardiovascular risk factor with the score is recommended, should be calculated a score. In average patient more or equal to 70 years without established atherosclerosis cardiovascular disease, diabetic, CKD, and genetic rare lipid or blood pressure, estimation 10 years fatal and non-fatal cardiovascular disease risk with a score is recommended. Patient established atherosclerosis cardiovascular disease or diabetic or moderate to severe renal disease and or genetic or rare lipid or blood pressure disorder are to be considered at high or very high risk cardiovascular disease. Also, the new recommendation about risk factor and clinical condition, stepwise treatment and intensification approach aiming at intensive risk factor treatment is recommended for apparent health people at high or very high risk of atherosclerosis cardiovascular disease, as well as patients with established atherosclerosis cardiovascular disease and or patient diabetic with consideration cardiovascular risk, treatment benefit of the risk factor, risk modifier, comorbidity, and patient preference. Class 1. The treatment of atherosclerosis cardiovascular disease risk factor is recommended about health people without diabetic CKD, genetic and rare lipid or blood pressure disorder who are at very high risk cardiovascular disease according to the age. If age under 50, if it score more or equal 7.5, that means very high. If age between 50 to 69, above 10, that means the very high risk factor. If patient more than 70 years, they score more or equal 15, that means very high. Uninformed discussion about cardiovascular disease risk and treatment benefit tailored to the need of the patient is recommended class 1. Also, it is recommended to reduce sedentary times to engage in at least light activity throughout the day to reduce the all cause of and cardiovascular mortality and morbidity. Class 1. It's recommended to adopt Mediterranean or similar diet to lower the risk of cardiovascular disease. Also, it's recommended to restrict alcohol consumption to maximum 100 grams per week. It's recommended to eat the fish and at least a week and restricted the meat. In patient mental disorder needed intensified attention and support to improve adherence of life change and drug treatment. Smoking should be stopped. Smoking is the major risk factor of serious cardiovascular disease. Smoking is recommended to stop regarding the weight gain, as the weight gain does not lessen the atherosclerosis cardiovascular benefit of cessation. In patients with established atherosclerosis cardiovascular disease, as you know, that means very high risk factor should be target and keep the LDL concentration less than 1.4 millimole per liter, equal 55 milligram per deciliter, and more or equal 50% reduction in LDL versus baseline is recommended. For secondary prevention in patients not achieve their goal by maximum tolerated dose of statin and ezetimibe combination therapy, including PCSK9, is recommended, class 1. In patient diabetes type 2 at very high risk, same should be keep the LDL level less than 1.4 millimole, equal 55, less than 55 milligram per deciliter is recommended. If in patient with diabetic type 2 and high risk should be keep the LDL level less than 1.8 millimole per liter, equal 70 milligram per deciliter is recommended. Also, to reduce the atherosclerosis cardiovascular disease, it's recommended that first objective the treatment is to lower the blood pressure less than 140/90 in all patients, and that subsequent the blood pressure target are tailored to age and specific comorbidity. For example, age between 18 to 69 should be kept the systolic blood pressure between 120 to 130. If patient above 70 or equal should be kept the blood pressure, systolic blood pressure between 130 to 140. In all treated patients, the systolic blood pressure recommended lower to 80 millimeter per mercury. Also, in patients with diabetic type 2 and target organ damage, that means patient very high risk for atherosclerosis cardiovascular disease, the use of SGL cotransporter 2 inhibitor or glucagon peptide 1 receptor agonist to protein outcome benefit may be considered to reduce future cardiovascular disease and total mortality. For primary prevention patients at very high risk but without familial hyperglycemia, if LDL goal not give a maximum tolerated dose of statin and ezetimibe combination with PCSK9 may be considered as primary prevention, this 2B. As secondary prevention, it's 1A. In high-risk patient or above high or very high-risk patient, triglyceride more than 1.5 millimole per liter equal 135 per deciliter despite the statin treatment and lifestyle measurement. Polyunsaturated fatty acid may be considered in combination with statin. Initiation of statin for primary prevention in all patients more than 70 may be considered if patient high risk or very high risk. The statin may be considered in person age less than or equal 40 years with diabetic type 1 or type 2 of organ damage and or LDL level more than 2.6 as long as pregnancy is not being planned to be. In patient diabetic and very high, at high or very high cardiovascular risk, low dose of statin may be considered as primary prevention if no clear contraindication. Home-based cardiac rehabilitation, telehealth, and medical health intervention may be considered to increase the patient participation and long-term adherence to health behavior. In patients with heart failure, major depression, selective troponin inhibitor, and troponin noradrenaline selective inhibitor and tricycline depression is not recommended. In patients with dialysis, dependent CKD or free atherosclerosis, conventional statin is not recommended. This is about the cardiovascular risk factor and treatment in patients with established serious cardiovascular disease. First step should be stop the smoking and lifestyle modifications, class 1, and systolic blood pressure should be kept between 140 to 130, and LDL should be reduction about 50% from baseline and 1.8 in first visit, and the target LDL in very high risk should be kept less than 1.4 equal 55 milligram per deciliter, and to reduce to follow the patient with established cardiovascular disease should be check the LDL every 4 to 6 weeks, and then if patient not tolerated should be added another lipid lowering drug. Here corresponding HDL and cholesterol and apolipoprotein level for commonly used in LDL cholesterol. For example, 2.6 millimole per liter LDL equals 3.4 and equal 100 milligram per deciliter apolipoprotein. And here very nice is slide about the intensity of lipid lowering drug. The moderate intensity statin reduces the LDL cholesterol reduction about 30%, high intensity statin reduction the LDL about 50%, high intensity statin plus ezetimibe reduce the LDL by 65%, PCSK9 inhibitor alone reduce the LDL by 60%, PCSK9 plus high intensity statin reduce the LDL 75%, if PCSK9 plus high intensity statin and ezetimibe reduce the LDL 85%. And what about patient age more than 70 or equal 70? The patient established serious cardiovascular disease, lipid lowering drug with ultimate LDL cholesterol goal less than 50% or equal reduction from baseline and keep LDL less than 1.4. Goal not achieved by maximum dose, tolerated dose statin combination ezetimibe. For primary prevention, very high risk but without familial hypercholesterolemia, if LDL goal, cholesterol goal is not achieved by maximum tolerated dose of statin and ezetimibe combination PCSK9 may be considered. In secondary prevention, patients not achieve their goal, maximum tolerated dose of statin and ezetimibe combination PCSK9 is recommended. For secondary prevention, class 1, for primary prevention, class 2B. For very high risk familial hypercholesterolemia, that is with atherosclerosis cardiovascular disease or with another major risk factor who does not achieve goal maximum tolerated dose of statin ezetimibe combination PCSK9 inhibitor is recommended. A statin-based regime is not tolerated at any dose even after regain, ezetimibe should be considered as first line. If statin-based regime is not tolerated at any dose, even after regain, PCSK9 added to ezetimibe may be considered as class 2B. If goal not achieved, a statin combination with bile acid may be considered. Statin therapy is not recommended in premenopausal female patients who are considering pregnancy or are not using adequate contraceptive. As you know, statin is contraindication during pregnancy. Statin treatment is recommended as a first-line choice for reduce the cardiovascular disease in high-risk individual with hypertriglyceridemia. If triglycerides cut more than 2.3 millimole per liter equals 200 milligram per deciliter. In patients take statin who LDL cholesterol goal with triglyceride more than 2.3, fenofibrate or pentofibrate may be considered. In high risk or above, triglyceride more than 1.5 equal 135 milligram per deciliter, despite maximum dose of statin, lifestyle measurement, polyunsaturated fatty acid may be considered this combination with statin. Treatment statin for older people with a serious cardiovascular disease, same dose as for younger patients. Initiation of statin for primary preparation in all people age more or equal 70 may be considered if high or very high risk. That means if all patients all people more than 70 years, not recommended to give statin as primary prevention if moderate risk or low risk. It recommended that statin is started at low dose if is significant impairment and or potential for drug interaction. Use of statin or statin plus ezetimibe combination is recommended for patient non-dialyzed stage CKD 3 or 5 stage. Patient already on statin and ezetimibe or statin plus ezetimibe combination at the time of dialysis initiation, continuation of these drugs should be considered, particularly in patients with a serious cardiovascular disease. In patients with dialysis-dependent CKD and interstitial disease who are free of a serious cardiovascular disease, commencing statin therapy is not recommended. Not recommended for give interstitial disease dialysis-dependent to give statin as primary prevention. Thank you for your attention.
Thank you very much. Thank you very much, Mujahed. Very thorough and comprehensive review of the latest guidelines. I'm going to talk a few minutes because Dr. Abdulmunim Assid, who is the president of the Sudan Heart Society, is driving home now, and he said he'll be with us hopefully within 5 minutes, and we will be able to have him. So meanwhile, I'll just shed a few points, and then I'll refer some of the questions to you, Mujahed. I think we have a question that how do you see patients with chronic inflammatory conditions like rheumatoid arthritis in the lipid management map? What are your recommendations? How shall we consider these patients who have chronic inflammatory conditions? They mentioned specific rheumatic heart disease and other autoimmune inflammatory conditions. What's your take about these patients?
The chronic inflammatory disease is specific disease for, and it is risk for associated cardiovascular disease. First, I case to calculate the risk classification and associated cardiovascular disease according to the score to and if the patient on very high risk or high risk should be prescribed first line statin and keep the LDL level according to the score level.
Okay, thank you very much. I think you have a number of people who have congratulated you on your presentation. A lot of questions come in the chat as is this going to be a single clinic? And I think Dr. Mutaz Subah have answered that question. And he said that we're aiming for a lipid network in Sudan and a minimum of 3 clinics. He mentioned that number. And I think we will work together to meet these expectations, inshallah, of having more clinics for lipid management. Dr. Najla, who is a young and promising cardiologist at Madani Heart Center in the Jazeera State, have shown interest, and I think we can all work together. And now Dr. Mutaz is saying that he will contact you, Dr. Mujahed and Najla, on how to move forward. I think after we finish, we can form a WhatsApp group of the interested people. We have a question. It says, very nice presentation, Mujahed. 50% reduction with how much? In how much time? So they ask, what do you mean by 50% reduction in the LDL, and how much time would you achieve that 50% reduction?
The reduction according to the intensity of statin, and the time, I think, 4 to 6 weeks, and then should be checked the LDL every 4 to 6 weeks.
So okay, so that's the one question there we have. Somebody asked about whether monoclonal antibodies are available. So I guess they're talking about PCSK9 inhibitors. The question to you, Mujahed, are they available in Sudan or no? And what's your vision for that, since you'll be leading the effort at Shab Teaching Hospital?
We appreciate it to get as soon, inshallah, the PCSK9, as you know, it is very potent drug. Is alone is the reduction of the LDL about 60%. If added to high intensity atorvastatin and ezetimibe, reduction of the LDL about 85%. Will be there alone soon, inshallah.
Okay. Inshallah, yeah, they're not available. I think, Doctor, we've discussed this issue. Thank you, Mujahed. I think you had great opinions there. You have discussed this issue, and we have talked to some of the industry partners, hoping that we might be able to get the PCSK9 inhibitors via the National Medical Supplies Fund. We can identify people with familial hypercholesterolemia, and maybe we can provide them at lower cost, just like cancer therapy or chemotherapy is provided. Dr. Mujahed, I think, has great opinions on this one, and part of what his lipid management, lipid clinic is to advocacy, as well as working with the industry and the regulatory bodies in the country to provide much needed drugs. The other question is, you've mentioned ezetimibe. Is ezetimibe available in Sudan? And have you used it? Is it available? Any plans for ezetimibe, Mujahed?
It's not available. It's not available in Sudan, but inshallah, as soon inshallah we get it. Inshallah, it's not available, unfortunately.
Yeah, I think we had a meeting with the industry a couple of these, and then one of them is start the process of registration of ezetimibe in Sudan. And the question to you also we have a question again here. From the lipid, sorry again, so we have one more question is from the endocrinologist, is especially posted twice. where do we see in your clinic diet, therapy, and exercise? I think they meant lifestyle modification. So what would be your plan for that? Is it going to be part of a clinic? How do you look at that aspect of lipid management?
As you know, lipid lowering clinic, it's concerned about the importance of lipid lowering drug and importance of lifestyle modification. As you know, it should be discussed with the patient about the atherosclerosis cardiovascular disease, lifestyle modifications, diet management, and nutritional management, and should be then follow the LDL level. And many of people now complain of atherosclerosis cardiovascular disease, and the atherosclerosis cardiovascular disease is the major fatal condition and should be treated and prevented by lifestyle modification and lipid lowering drug. Our physician to consider now and to apply this intervention to reduce the risk of atherosclerosis cardiovascular disease and to follow the patient better than.
Thank you, Mujahed. I think we'll continue for this another 5 minutes. Hopefully, Professor Abdulmunim Masid will join us. A question just came up. It says, how would you manage patients with CKD and high total cholesterol? How would you manage CKD with high total cholesterol?
Yep. CKD as primary prevention is not advised to give atorvastatin as primary prevention. This is number one. Number two, as secondary prevention, according to the stage of CKD. If dependent of end-stage disease stage 5 is started by small dose and keep LDL according to the risk stratification. If very high, less than 1.4 millimole per liter. If high, less than 1.8. If patient with end-stage disease is started by small dose of atorvastatin.
Okay, so
not advised to give atorvastatin as primary prevention for CKD or end-stage disease.
Okay, are you aiming for if patient has no concomitant diseases with CKD? Are you aiming for a certain LDL level if they have only CKD isolated?
No,
and how would that how would you calculate the risk score? Would the risk score be the same as non-CKD patients?
Yep, risk score is depend on the age and gender and smoking, if patient smoking or not, and total cholesterol level and systolic blood pressure. CKD is not apart from atherosclerosis cardiovascular disease. It's the one with the major condition and major disease of atherosclerosis, but it's not change the risk score. That means CKD alone is not advised to give statin as primary prevention. If is another major risk factor, that means in very high or high risk, and give the atorvastatin.
So just like I did with Dr. Mutaz, so before we end up this webinar, if you have a number of messages, just clear bullets to the audience, especially some have joined late. So what are your major advices to your audience? Now we have quite a huge, we have 53 participants despite everything. So what are your major take-home messages, Mujahed? Especially a lot of them are younger colleagues. What's your take-home message from your presentation?
Yeah, phase should be classified the people according to the atherosclerosis cardiovascular disease, define very high risk factor and risk factor, and then treated the risk factors, treated the diabetic, and keep the LDL level less than 1.4 millimole per liter if patient very high, and 1.8 millimole per liter if the patient high. And also it's very important to lifestyle modification by exercise and diet control, stop the smoking and reduction the alcohol, and encourage the fish diet, and control the LDL level by statin high dose, high intensity statin. If not reach the goal, added the ezetimibe or PCSK9 to keep LDL as a lower as. And also, if patient with ACS, cirrhosis, and not tolerated to the statin or small dose of atorvastatin, may be changed to the ezetimibe as the first line. In this regional disease and CKD, not advised to give atorvastatin as primary prevention.
Thank you very much, Mujahed. I think we have to conclude very soon. Professor Abdul Munim Al-Seed was supposed to join us. He's the president of Sudan Heart Society. He gave me a phone call. He had issue with, he has a social issue and he's driving back home, but it seems that he hasn't been able to join us so far. He was supposed to give a talk on the unmet needs for lipid management in Sudan. And I think my personal take on this issue would be a lot of things are missing from public awareness about the importance of measuring lipid levels in the blood as part of a preventive cardiology program, including diabetes, hypertension, improving lifestyle modification, healthy diet, weight loss programs, managing weight. So I think the first thing is public awareness about lipids and the importance of that. And the other issue is providing early detection of cases, especially familial hypercholesterolemia. And we did a lot of work, as Dr. Mutaz have said, with school health, with pediatricians, endocrinologists, and everybody involved in the field about early recognition of the disease, and having a place where there is a referral clinic where patients can be followed up. So this is part of that effort, a lipid clinic, and hence a clinic network. Availability of lab measurements, especially in the public service, where it is accessible with the national insurance. We have done that at least the basic panel at Shab Teaching Hospital. And we're also exploring other important parameters like lipoprotein A levels, and also hopefully direct measurement of LDL cases with very high lipid levels. We need to make sure that the drugs are available, especially high potency statins in the national insurance, so it's available. We're working on providing we need to provide drugs and medications, including ezetimibe and PCK9, as I related to Mujahed. I think the pediatricians and Professor Abdul Munim is a pediatric cardiologist. They're having a number of families and young patients who have real issue with follow-up and screening of familial hypercholesterolemia. I have to conclude here. I would like, before we conclude, I would like if the Ahmed can arrange for a screenshot for all the speakers, including all those of us who are on video, and a screenshot with the speakers. If you can arrange for that, Ahmed, so that we have a screenshot. Yeah, that's a good one. So we have, can we take a screenshot from here, Ahmed? Do you hear me, Ahmed? Can we take a screenshot? Can I get confirmation from you? I tried to take it from my mobile. Mujahed, you need to come back so we can have a screenshot of all the speakers. Meanwhile, I cannot thank Dr. Mutaz Al-Sabah for such a great effort.
I wish you all success, dear colleagues, and I shall support you till the establishment of Sudan Lipid Clinic.
Were you able to take a screenshot, Dr. Mutaz?
I shall try.
Were you able to take a
Yes.
screenshot? Dr. Mutaz, were you able to take a screenshot of the speakers?
Yes.
Okay, perfect. So we can share
Okay,
that.
no problem.
All right, thank you very much. It's been a great evening. We have so far 50 participants. Thank you very much for all your support. Have a great weekend. Enjoy your evening and good night. And see you soon. Another webinar about lipids and lipid management. Thank you very much. Thank you very much. And have a good night. Assalamu alaikum wa rahmatullahi wa barakatuh. Thank you.
Thank you. Thank you. Alaikum salam wa rahmatullah.